corrective option most likely to result in the success. This presentation highlights the complex nature of paravalvular leak and promising contemporary treatments options available. While pulmonary and tricuspid valve replacement is becoming more prevalent, there are very few reports on paravalvular leak in these locations, and therefore, in this presentation, we'll focus mainly on the left-sided valvular regurgitation. Starting with clinical presentations, paravalvular leak is a known complication of prosthetic valve replacement, which, when moderate or severe, is associated with more than twofold increase in all-cause mortality. Paravalvular leak is is clinically significant in 2 to 5% of the patient with surgical valve replacements. The majority of clinical presentations are due to heart failure. Over the time, chronic regurgitation can result in left atrial and left ventricular pressure and volume overload with pulmonary edema and symptoms of heart failure. However, even less severe regurgitation can cause heart failure if the receiving chamber is non-compliant, making the degree of regurgitation alone insufficient to judge its contribution to the patient's symptoms. The turbulence of paravalvular leak results in increased shear stress on the blood cells, which may also result in signs or symptoms of hemolytic anemia. This occurs more frequently in patients with smaller paravalvular defects, whereas larger defects are typically associated with heart failure. It has been estimated that between 33 to 75% with symptomatic paravalvular leak will have clinically significant hemolysis. Hemolytic anemia often present insidiously with new onset fatigue but can progress to include conjunctival and mucosal parapetechi and even overt jaundice. Patients may require blood or platelet transfusions in the light of significant anemia. Importantly, it is estimated that 18 to 51% and 5 to 10% of the patients will have subclinical hemolysis with contemporary mechanical and tissue prosthesis, respectively. That is, patients with laboratory evidence of hemolysis without associated anemia. Since patients with paravalvular leak have an associated paravalvular defect, they are also at risk for development of endocarditis in the presence of bacteremia. Uh, uh, like surgical valve replacement, paravalvular leak after transcatheter aortic valve replacement can also result in heart failure, hemolytic anemia, or endocarditis. Most recent estimates suggest that moderate to severe paravalvular leak occurs in approximately 2.5% of patients post-procedurally. Studies evaluating the overall impact of mild paravalvular leak after transcatheter aortic valve replacement have yielded conflicting results. While it was generally believed that only moderate to severe regurgitation would affect long-term outcomes, analysis from the partner trial showed that even mild paravalvular leak after TAVR is associated with increased mortality. Conversely, other large registries have only demonstrated adverse effects of a moderate or greater paravalvular leak. Interestingly, it has been suggested that paravalvular leak only impacts uh, post-shower outcomes in patients without pre-existing aortic regurgitation. Specifically, patients with small hypertrophied ventricles are unable to tolerate any increase in volume loading from any degree of paravalvular leak, even if only mild in severity. New murmurs that could be consistent with paravalvular leak, that is, holosystolic murmur in patient with mitral prosthesis or a diastolic murmur of aortic regurgitation in a patient with aortic prosthesis, should be investigated with further imaging. Conversely, however, clinically significant paravalvular leak may only be associated with a soft murmur. So, a high index of suspicion should be maintained when evaluating a patient for possible paravalvular leak. Predisposing factors, location. The location of the replaced valve is important predisposing factor of a paravalvular leak. Paravalvular leak has been found to be twice as likely with mitral versus aortic prosthesis. Furthermore, the location of paravalvular leak has significant prognostic implications. There is data to suggest that paravalvular leak in mitral position, regardless of severity, has an increasingly lower event-free survival, defined as cardiac or all-cause mortality, repeat surgery, or urgent admission for heart failure, compared to the aortic position. Surgical versus transcatheter approach. Reported rate of surgical and transcatheter PVL has been variable over time. Data from numerous studies have shown that paravalvular leak post-TAVR, regardless of severity, conveys poor outcomes. Mild paravalvular leak post tower was independently associated with decreased survival as well as associated with all-cause and cardiovascular associated mortality. Sex appears to be distinguishing factors with regard to incidence of paravalvular leak. Inclusive of all paravalvular grades, females have found to be lower incidence of paravalvular leak compared to males, collaborated by partner trials and several meta-analyses. The mechanism is likely related to small and inherent annular size, leading to an increased likelihood of oversizing the valve. Additionally, females typically have less aortic valve calcification, a known predictor of paravalvular leak and a likely contributory factor to the observed sex difference. Technical considerations. Prosthetic paravalvular leak results from incomplete circumferential apposition of the prosthesis within the associated annulus, lack of direct visualization of the valve annulus in TAVR, and the reliance on surrogate visualization through fluoroscopy and intraprocedural echocardiography are prominent predisposing factors. The aortic annulus size, position, and prosthetic valve and pattern of calcification in the native valve are known to play significant role in increasing the risk of paravalvular leak. Accurate sizing before valve implantation is paramount in avoiding paravalvular leak. Consequences of inaccurate oversizing may include annular rupture, coronary artery occlusion, and arrhythmias.
Mm.
Valvular calcium typically creates asymmetric shape and can prevent full apposition of the valve with the aortic root. Several quantitative measures characterizing the degree and pattern of aortic root calcium has been found to predict the likelihood of paravalvular leak. High Agatston scores determined based on ECG-gated contrast, enhanced computed tomography, as well as cusp calcification at the aortic wall were strongly predictive of paravalvular leak. Additionally, an echocardiographic calcification score has been devised for the prediction of paravalvular leak, yielding a similar results as the CT-based prediction. The angle of the left ventricular outflow tract to the ascending aorta also has been found to be an independent predictor of paravalvular leak, as a greater angle prevents adequate closure or sealing of paravalvular space. Additionally, in TAVI, a low position of the prosthetic valve in relation to the native valve annulus may allow regurgitation through the stent frame. Conversely, high positioning of the valve in relation to the valve apparatus can allow blood flow between the prosthesis and the annulus. In surgical valve replacements, specifically, risk factor for the occurrence of paravalvular leak include supraannular placement of aortic valve, continuous sutures and mitral valve, suture technique without pledget use, and smaller body surface area. Moving on to diagnosis and evaluation, the diagnosis of paravalvular leak is challenging and requires multimodality imaging to both diagnose and treat. While echocardiographic assessment is the mainstay of evaluation, computed tomographies as well as cardiac magnetic resonance imaging are also valuable assessment tools. Echocardiography. Transthoracic echocardiogram is the initial diagnostic test of choice for all patients with suspected paravalvular leak. Echocardiography is widely and readily available, is non-invasive, and provides a direct visualization of prostatic valve function. Two-dimensional, three-dimensional, and Doppler assessment of the prostatic valve should be performed in addition to a comprehensive cardiac evaluation of atrial and ventricular size and function, pulmonary artery systolic pressure, and concomitant native valvular disease. Additionally, given the association of paravalvular leak with endocarditis, careful investigation should be pursued for independently mobile masses on either the prosthetic or native valves. While transthoracic echocardiography is a superior method of assessment of valvular gradients and overall cardiac function, it is often limited by acoustic shadowing from mechanical components of the prosthetic valve. Example, bileaflet tilting disc, acute biprostatic leaflet or annular calcification, prostatic valve seeing rings and struts, or the TAVR prosthesis skirt. Acoustic shadowing not only precludes visualization of prostatic valve components but may also result in absence of color Doppler signals with potential underestimation of the degree of paravalvular leak and difficulty in delineating valvular versus paravalvular regurgitation. This is specifically true for the assessment of mitral valve prosthesis, where paravalvular leak may only be detected in off-axis imaging, example subcostal sleeve, and not seen at all. For aortic valve, prosthetic valves, posterior paravalvular leak may be missed due to anterior acoustic shadowing. For prosthetic valves, Doppler evaluation can be critical clue for presence of significant or underestimated paravalvular leak. This includes elevated Doppler velocity across prosthetic valves, dense continuous wave Doppler tracings, rapid continuous wave Doppler deceleration times, hollow diastolic flow reversal in the descending aorta for aortic surgical prosthesis or and TAVR, or pulmonary vein flow reversal for mitral surgical prosthesis. This figure shows transthoracic echocardiography image of a patient with aortic paravalvular leak. In figure A, we can see 120-degree view of the aortic valve, while figure B shows a biplane view, which shows two major areas of leak. Transesophageal cardiography is usually the subsequent diagnostic test pursued in patients with suspected clinically significant or confirmed paravalvular leak. Uh, TE plays a major role in delineation of the degree and mechanism of paravalvular leak and is important in clarifying whether there is eccentric valvular versus paravalvular regurgitation. For patients with mitral valve prosthesis, transesophageal echocardiography is the method of choice for assessment of paravalvular leak in the degree of acoustic shadowing that is present. Conversely, however, aortic valve prosthesis, especially with the TAVR valve, is generally well evaluated by transthoracic echocardiography imaging. Transesophageal echocardiographic imaging has the advantage of imaging the posterior aspects of the aortic prosthesis, but is limited by anterior prosthesis acoustic shadowing. Thorough evaluation with mid-esophageal and deep transgastric views is essential for complete quantification of the paravalvular leak. 3D transesophageal echocardiography can be invaluable in localizing paravalvular leak, particularly intraoperatively, but suffers from the same shadowing limitation as the 2D echocardiography and generally has a lower spatial and a temporal resolution. Moreover, dropout artifacts may occur, leading to inappropriate diagnosis of paravalvular leak when no such defects exists. Therefore, integrating 2D and 3D imaging is essential in accurate paravalvular leak diagnosis. Transesophageal echocardiography is also an essential component of pre-procedure planning, particularly if transcatheter closure will be performed. It is also crucial to rule out any active endocarditis, excessive rocking motion of the prosthesis, that is dehiscence, or significant valvular regurgitation. In this image, we can see the image A shows a TE image with paravalvular leak of mechanical aortic valve, long axis view, but no clear whether it's valvular or paravalvular. Then B and C shows the transgastric views with the visible tract around the aortic valve, suggest you have paravalvular leak. D shows a cineangiography with the serpiginous and eccentric course of the paravalvular leak. E shows the mechanical valve prosthesis paravalvular leak. F and G shows the 3D image of the mitral valve prosthesis from a surgeon's view with the left atrial appendage positioned laterally at 9 o'clock position, aortic valve at 12 o'clock position, and intraatrial septum at 3 o'clock position. We can see the red arrows pointing the paravalvular leak in F and G. It is after the repair. We can see that there is no paravalvular leak now. Finally, it should be emphasized that paravalvular jets are commonly multiple, eccentric, and follow serpiginous tracks, making them challenging to image and quantify by echocardiography. Thorough prosthetic valve interrogation should be pursued with multiple views and off-axis imaging if necessary, in order to best quantify the degree of paravalvular leak and differentiate between valvular and paravalvular regurgitation. To ensure effective and consistent communication between the echocardiographer, interventional cardiologist, and the cardiac surgeon, a standardized orientation and nomenclature are used to define the paravalvular defects. On 3D imaging, as we saw in a mitral valve prosthesis, are oriented such that the aortic valve is located anteriorly at the 12 o'clock position, the interatrial septum medially at 3 o'clock position, and the left atrial appendage laterally at 9 o'clock position, also known as the surgeon's view. Like mitral valve prosthesis, aortic prosthesis are oriented in the short axis view such that the location of paravalvular leak can be reported in terms of a clock phase. In the aortic valve prosthesis, we can see interatrial septum medially and at 9 o'clock position. Alternatively, the origin of paravalvular leak can be identified with respect to native aortic valve cusp location, that is right, left, or non-coronary cusp. Also, the use of intraprocedural transesophageal echocardiography, including 3D TE, is standard of care when performing catheter-based procedures to correct the paravalvular leak. Moving on to cardiac computed tomography, in situations where TTE and TE are unable to clearly delineate the extent and location of paravalvular leak, cardiac CT has emerged as a useful adjunct imaging technique. Preoperative assessment with cardiac CT to assess the size and shape of the aortic annulus has shown to decrease the degree of post-TAVR paravalvular leak compared with the 2D echocardiography. Moreover, it can evaluate the location and degree of annular calcification, another risk factor for paravalvular leak. Studies have mostly suggested that cardiac CT has no advantage of paravalvular leak detection in comparison with the 2D esophageal echocardiography, although a recently study did suggest similar efficacy between two evaluation of prosthetic mitral valve. Limitation of cardiac CT includes its requirement for intravenous contrast, the exposure to ionizing radiation, the difficult cardiac gating for rapid or irregular heart rates. However, cardiac CT can be invaluable in the anatomical characterization of the paravalvular leak in patients with significantly limited echocardiographic images and help define optimal fluoroscopic angles of the prostatic annular plane to be used for paravalvular leak closure. Here we can see cardiac CT image with 3D reconstruction post mitral valve leak closure with amplatzer vascular plug in place along the anterior margin. Moving on to cardiac MRI, cardiac MRI can be utilized to diagnose and quantify the degree of regurgitation in patients with aortic valve and mitral valve prosthesis where TTE and TEE have failed to adequately do so. Importantly, virtually all prosthetic valves, including mechanical valves, can be imaged by cardiac MRI. Phase contrast velocity mapping is performed in short axis plane just distal through the prosthetic valve with subsequent quantification of regurgitant volume and regurgitant fraction. Important limitations of cardiac MRI include its tendency to overestimate the degree of paravalvular leak compared with to echocardiography due to incorporation of coronary flow and decreased accuracy in setting of arrhythmia. Nonetheless, cardiac MRI can play a major role in quantifying paravalvular leak in presence of multiple eccentric and irregularly directed rates and when there is significant acoustic shadowing on echocardiography. This shows the representative views of paravalvular regurgitation on cardiac MRI with calculation of regurgitant volume. Moving on to cineangiography. While cineangiography with an aortic root injection can be used for the determination of the total degree of aortic regurgitation, this is typically related to evaluation during TAVR given its invasive nature and and contrast associated risk. Moreover, angiographic grading of aortic regurgitation correlates poorly with other assessment of regurgitant severity and cannot reliably delineate central and paravalvular aortic regurgitation. Here we can see the cineangiographic views of a posterior PVL, which then amplifier paravalvular leak plug has been placed, and then again contrast has been injected, and then we can see that there is no paravalvular leak as seen before. Quantitation of paravalvular leak. Once it has been established that there is paravalvular rather than valvular regurgitation, quantification is essential. Estimating the severity of aortic paravalvular leak can be very challenging due to acoustic shadowing and the garden horse effect, wherein color Doppler may occupy the entire ventricular outflow tract despite blood only traveling through a small albeit serpiginous tract. Conversely, mitral paravalvular leak is easier to evaluate on transesophageal echocardiography with excellent 3D reconstruction for optimal localization and sizing of the defect prior to any intervention. Quantification of paravalvular leak is typically accomplished through 2D and 3D echocardiography, but also assessed by cardiac CT, cardiac MRI, and cineangiography. Multiple grading systems have been created for the evaluation of paravalvular, including a 3-class, an angiographic 4-class, and unifying 5-class grading scheme. Here in the table, we can see the 3 class, 4 class, and a unifying 5 class grading scheme. Of 3 class grading schemes is classified as mild, moderate, and severe. 4 class include the grade 1, 2, and 3, and 4. And unifying 5 class grading scheme include trace, mild, mild to moderate, moderate, moderate to severe, and severe grades. The various echocardiography and Doppler parameters which are included are these are structural parameters first, that is the valve strain, left ventricular size, then Doppler parameters, the jet features, then width of the jet, multiple jet or the jet path, then vena contracta area in 2D and 3D Doppler, then jet width, that is LVOT diameter, then jet density, uh, and diastolic flow reversal in the descending aorta also. And parameter, that is quantitative parameters, include regurgitant volume, regurgitant fraction, and effective regurgitant orifice area. Based on this, paravalvular leaks are classified into various grades. Indications for paravalvular leak closure. Indications of paravalvular leak closure include the presence of symptoms of dyspnea or clinically significant hemolytic anemia and moderately severe or severe paravalvular prostatic regurgitation. The indications also vary depending on the treatment modality being used, that is surgical or transcatheter closure. Important contraindications to paravalvular leak closure include active endocarditis, regurgitation involving more than one-third of the circumference of the prostatic annulus, or an unstable or rocking prosthesis, and intracardiac thrombi or vegetation that may be dislodged during the procedure. Although medical therapy can improve symptoms, progression of heart failure from volume and pressure overload, as well as need for repeat red blood transfusion, often cannot be corrected without the closure of the defect. This is the decision-making algorithm for diagnosis and treatment of paravalvular leak. Once suspected mitral or aortic paravalvular leak, we have to assess how hemodynamically significant the leak is by TT or transesophageal echocardiography. If there is significant hemolytic anemia present, then we have to move on for a specific management of the paravalvular leak. Medical management cannot be done in that case. If symptoms are present, then medical management can be tried, but if no relief, then we have to move on to the specific paravalvular leak closures techniques. Any contraindication to the paravalvular leak is present, then medical management is the choice, or we can consider surgical repair. If anatomy is suitable for transcatheter paravalvular leak closure, then transcatheter paravalvular leak closure is preferable. And if anatomy is not suitable, then we have to consider surgical repair. Moving on to treatment aspect, medical therapy. While medical therapy is an important component of symptom management for patients with hemolysis or heart failure due to paravalvular leak, there are no known medical therapies to prevent or reverse paravalvular leak or its underlying cause. Only surgical repair or transcatheter intervention provides definitive treatment. For patients with severe heart failure, medical management should mimic the recommendations for patients with symptomatic mitral regurgitation and aortic insufficiency. These include diuretic therapy for volume overload and afterload reduction in patients with hypertension. Similarly, in patients with endocarditis, appropriate antibiotic therapy should be instituted. For patients with hemolytic anemia, red blood cells destruction results in accelerated erythropoiesis. As a result patients should receive folic acid and iron supplementation, either oral or intravenous. In some cases, hemolytic anemia may be so severe to warrant transfusion, although there is no agreed upon threshold to transfuse to, which is also influenced by patient comorbidities. In limited retrospective studies, beta blockers have demonstrated to improvement in hemolytic anemia postulated to occur due to decrease in red blood cell shear stress. Similarly, erythropoietin has been used with some success in patients with paravalvular leak who were able to undergo surgical replacement, but in small patient series. Surgical replacement. Based on the 2017 American Heart Association focus guidelines update for the management of valvular heart disease, surgical valve replacement is class 1 indication for operable patients with mechanical valves with intractable hemolysis or heart failure due to severe paravalvular leak. For many patients, surgical replacement may carry moderate to high operative risk. This is a result of necessity for a redo operation and the fact that most patients are typically older with greater number of comorbidities. Surgery is the treatment of choice to address paravalvular leak in symptomatic patients at acceptable risk. The surgical strategy is decided based on the factors such as patient status, the etiology, the condition of the native annulus, the size and location of the leak, and whether the area is accessible. When the left ventricle is decompressed, the surrounding anatomy becomes distorted, making paravalvular leak difficult to detect or localize. Therefore, a perioperative real-time 3D transesophageal imaging would be a great guide for surgeons to identify the location of the paravalvular leak. Surgical options include paravalvular leak repair or prosthesis replacement. The type of surgery depends on the size and extent of the paravalvular leak, the condition of the native valve ring, and the patient's surgical history. Repair of paravalvular leak includes several techniques such as direct suturing in case of a small or well-seated paravalvular leaks, use of patches, or incorporation of a healthy full-thickness autologous tissue. They can be technically demanding due to presence of friable tissue fibrosis and calcification from the previous infection. This may also be associated with uncorrected annulus and unstable sutures left, leading to clinically significant residual paravalvular leak after the surgery. The decision to repair paravalvular leak or replace the prosthesis depends on the experience of the operators and the surgical volume as well as the anatomical characteristics of the paravalvular leak. Moving on to transcatheter repair. For patients with high surgical risk and severe symptomatic paravalvular leak, transcatheter repair carries a class 2A indication according to 2017 AHA focus guidelines update for the management of valvular heart disease. Critically, it should be noted that transcatheter paravalvular leak is contraindicated in patients with active endocarditis, rocking motion, or instability of the prosthesis, that is valvular dehiscence, and paravalvular leak involving 30% of the swing ring, more than 30% of the swing ring, that is a relative contraindication. Careful review of available images and discussion among team members are key pre-procedural steps for optimal outcomes. Pre-procedural planning should be performed using 2D and 3D transthoracic and transesophageal echocardiography in addition to cardiac CT scanning, which can help better define the extent and shape of the paravalvular leak and find the optimal fluoroscopic angle. The chosen device should be larger than the defect to avoid embolization, but should not be so large so as to interfere with the valve function, particularly when intervening on mechanical valves. Interventional cardiologists should have skill and facility with complex catheter techniques, including transseptal puncture, wire snaring, rail creation, delivery of vascular plug devices, and most importantly, the integration of fluoroscopic and echocardiographic imaging. Intra-procedurally, communication of cardiac imaging findings between echocardiographer and the interventional cardiologist is essential for defect localization, crossing of the interatrial septum, device maneuvering, wire crossing of the paravalvular defect, device positioning, assessing the degree of residual regurgitation, evaluation of possible interference with valve function, and deciding on the need for further intervention. Importantly, no device has been specifically approved for paravalvular closure by the FDA. Rather, self-expander occluder devices are used in an off-label fashion depending on the size and shape of the paravalvular leak. The majority are Amplatzer, that is by St. Jude now Abbott, and St. Paul devices, and include the Amplatzer vascular plug AVP family of occluder devices, that is AVP 2, 3, and AVP 4. The Amplatzer duct occluder ADO1 and ADO2, the Amplatzer atrial septal occluder ASO, and the Amplatzer muscular ventricular septal defect occluder. The AVP2 and AVP4 devices are most commonly used and have the benefit of being recapturable after deployment. AVP3 device is unique due to its oblong shape and is only available in Europe. The Occlutech uh, by Occlutech Labs in Germany. Paravalvular leak device is the first device to be designed specifically for paravalvular leak closure, and while it has demonstrated initial success, it is only available in Europe. Valve-in-valve procedures are able to utilize the existing structure provided by a previously implanted bioprosthetic valve to act as a roadmap for guiding the implantation of new bioprosthetic valves using a transcatheter approach. In this figure, we can see the various paravalvular leak closure devices. These include AVP2 and AVP3. AVP3, which is oblong in shape. This is AVP4. AVP2 and 4, we can adjust accordingly. That is, they can be maneuverized. Then ADO is the Amplatzer duct occluder device. Then ASO is Amplatzer atrial septal occluder, and AMVSDO is Amplatzer muscular ventricular septal occluder. Here we can see the occlutech devices, which is the first one is rectangular and other is the square shaped. Favorable and unfavorable characteristics for transcatheter closure of paravalvular leaks. These include favorable being if the distance is more than 5 mm from the swaying ring to the defect. If the distance is less than 2 mm, then it is unfavorable for transcatheter closure. And small PVLs are more favorable, and single paravalvular leaks are more favorable for transcatheter closure. Large paravalvular leak with multiple perforated sloped tunnel or a rocking valve or a calcified paravalvular tissue and infective endocarditis are more suitable for surgical closures. Transcatheter closure of mitral valve prosthesis for paravalvular leak. Transcatheter closure of mitral valve prosthesis for paravalvular leak is typically performed under general anesthesia given the importance of concomitant transesophageal imaging. There are three main procedures to closure of mitral PVL and include the antegrade transseptal, retrograde transaortic, and a retrograde transapical approaches. The antegrade transseptal approach is most commonly used and involves a transseptal puncture with subsequent wire crossing the paravalvular leak defect under transesophageal echocardiographic guidance. Importantly, a tip deflatable left atrial sheet is inserted that can be steered in three dimensions, allowing for the defect crossing and device placement. For added support when deploying multiple devices, the anchor wire technique can be used wherein a parallel body wire is maintained across the paravalvular defect during the deployment of the first device, allowing defect to reassess for deployment of additional devices if needed. Or a creation of a stable AV rail can be created wherein the wire is snared to the descending aorta via atrial puncture or in the left ventricular cavity via transapical access. Other techniques for transcatheter closure include the retrograde transaortic approach wherein atrial access is obtained and aortic valve is traversed and the paravalvular defect is crossed from left ventricle into the left atrium. Subsequently, the wire is snared by independently performed transeptal puncture, forming an atriovenous rail for device delivery. Finally, for patients with prior interatrial septal closures or those with medially located defects, transapical puncture should be considered. Although reported rates have varied widely, complications of transapical access for percutaneous interventions include hemothorax, pericardial effusion, and also coronary lacerations. For a mitral valve paravalvular leak, various approaches. These include antegrade from the left atrium, retrograde via the aorta, transapical, or atriovenous loop. Transcatheter closure of aortic valve prosthesis for paravalvular leak. This closure is most commonly performed by retroaortic approach using a femoral axis. The catheter-only technique is typically used for small defects that require only one closure device. The anchor wire technique preserves access across the defect by advancing a second wire into the left ventricle adjacent to the closure device delivery system. Finally, if a more stable rail is needed for deployment, a wire can be advanced across the paravalvular defect, retrograde through the aortic valve, and then snared in the descending aorta and exteriorized to the contralateral femoral artery. This atrioatrial rail technique is not recommended for patients with mechanical aortic valve due to the risk of immobilized leaflets and rapid hemodynamic deterioration from aortic regurgitation. One would expect that treatment of TAVR-related paravalvular leak is similar in principle to the treatment of paravalvular leak for surgically implanted aortic prosthesis. However, there are some important distinctions. First, for paravalvular leak that is due to TAVR underexpression or undersizing, primary therapy would be repetition of balloon dilatation. TAVR valves that are positioned too high or too low relative to the aortic annulus, valve-in-valve tower may be more appropriate therapy. The remainder of paravalvular closures, however, is technically similar to that of surgically implanted prosthesis. Importantly, these procedures may be complicated in TAVR patients owing to significant annular calcification, the presence of ceiling cut, and generally a smaller sized defects. Outcomes and complications of transcatheter repair, defined as mild or less residual regurgitation in absence of death or major complications. Successful paravalvular leak closure is achieved in approximately 70 to 85% of centers with procedure expertise. Successful reduction in residual paravalvular leak has been associated with decrease in cardiac mortality, less cardiac reoperations, and an improvement in NYHA functional class or hemolytic anemia. Similarly, residual leak after paravalvular has been corrected with increased all-cause mortality and major adverse cardiac effects. Despite its success, however, complications still occur in approximately 9% of the patients. In one study evaluating 115 patients, 30-day adverse event rates were 1.7 for sudden or unexplained death, 2.6 for stroke, zero point 0.9 for emergency surgery, 5.2 for periprocedural bleeding, and 1.7 for device embolization with retrieval. Another study examined 200 patients undergoing paravalvular leak closure, noting a 7% rate of MACE at 30 days. Interestingly, this same study emphasized the importance of a center experience with greater experience correlating with decreases in fluoroscopic time, procedural time, length of hospital stay, and MACE. Finally, 259 patients were evaluated in a multi-center series of paravalvular leak closures in which the majority were surgically implanted mitral and aortic valves. After a median follow-up of 110 days, adverse effects rates include 16.2 for death, 6% for recurrent valve surgery, 1.6 for significant hemolysis, and zero point 0.4 for device embolization, and zero point 0.4 for leaflet interference. There have been no prospective comparisons of surgical versus transcatheter paravalvular leak repair, especially considering many patients are referred for transcatheter repair because of high surgical risk. Indirect comparisons suggest that outcomes are similar. Surgical correction is associated with 30-day mortality of 8.8 to 11.5% and long-term survival of 30 to 57.8%. On meta-analysis, examined 2,373 patients who underwent surgical and transcatheter paravalvular leak closure. Interestingly, despite greater technical success in reducing paravalvular leak, surgical intervention appears to bring with it upfront cost, including higher 30-day mortality, 8.6% versus 6.8%, stroke 3.3% versus 1.4%, and hospitalization duration. However, by 1 year, there were no differences in mortality, 17.3 versus 17.2, and reoperation rates 9.1 versus 9.9, and NYHA class or heart failure readmissions. Moving on to conclusion, mitral or aortic paravalvular leaks are unfortunate but luckily relatively uncommon complications of prosthetic valve replacement that have important clinical consequences. Clinicians should be adept at recognizing this potential complication and characterization, and treatment of paravalvular leak will require multimodality imaging and specialized technical expertise. Using the many available tools and a multidisciplinary approach should lead the favorable outcomes in patients with paravalvular leak. Moving on to some review articles. One article, transcatheter closure or surgery for symptomatic paravalvular leaks in the multi-center case registry. This large-scale study aimed to retrospectively evaluate the long-term outcomes of patients who underwent reoperations or transcatheter closures of paravalvular leaks. It was published in December 23 in Journal of American Heart Association, and the conclusions were the current data suggested that percutaneous closure of paravalvular leak was associated with lower early but comparable long-term mortality rates with compared to surgery. Paravalvular leak after transcatheter aortic valve implantation is incidence, diagnosis, and clinical implication, prevention, management, and for future perspectives. This review article was published in Current Problems in Cardiology in October 22. 30 articles were selected for these review articles for inclusion. Incidence of paravalvular leak across the studies ranged from 7 to 40%. The conclusions were the correlation between paravalvular leak after TAVI has made it the most frequently studied post-TAVI complications. Although post-TAVI moderate to severe paravalvular leak can reasonably predictor of a decreased survival, the association of mild paravalvular leak with worse outcomes is still controversial and more thorough evaluation is warranted. Long-term results after surgical treatment of paravalvular leak in aortic and mitral position. This was published in Journal of Thoracic and Cardiovascular Surgery in May 2016. The aim of the study was to determine immediate results and long-term outcomes after surgical management of paravalvular leak. The conclusions were surgical treatment of paravalvular leak resulted in acceptable outcomes. Nevertheless, the continued risk of paravalvular leak recurrence is higher in patients who have had multiple previous surgeries. More studies were needed to compare these results with transcatheter paravalvular reduction techniques. Management of paravalvular leak post-aortic valve replacement. This was published in Journal of Cardiac Surgery in September 22. Conclusion was patients with paravalvular leak should be assessed through multidisciplinary team approach and patient selective plan should be in place. Open surgical intervention is reserved for complex cases where minimal invasive techniques cannot be utilized. A comprehensive review of the diagnosis and management of paravalvular leakage, which was published in Anatolian Journal of Cardiology in October 22. The transcatheter technique of for severe mitral paravalvular leaks can be offered as an initial therapy in experienced center, and as a transcatheter treatment does not preclude subsequent surgery as an alternative treatment, therefore allowing a stepwise approach to a challenging clinical disorder. Update in paravalvular leak closure, which was published recently in Current Cardiology Reports in July 21. The purpose of the review was given the low occurrence of clinically important paravalvular leak. There are no large registries or trials in this space to investigate management strategies. This review integrates newer evidence, particularly in imaging guidance for these complex procedures, novel techniques, and approaches that our group has taken, as well as approaches to more complex paravalvular leak plugging reported in the case reports. The summary of this article was gated cardiac CT has become key to the pre-procedure evaluation for transcatheter closure. The advent of purpose of built devices for paravalvular closure may further increase the efficiency and efficiency of percutaneous closure, but significant barriers remain for approval of these devices. Thank you.
Thank you, Shreyas. I think it was a good presentation, and especially the way you did the whole presentation, divided into the introduction, the various techniques, evaluation, and I particularly like the last bit where you have a review of literature and sort of give a summarized opinion on various techniques. There are a few comments I would like to just make. It is interesting to know that in your own initial slides you mentioned about 50 to 80% of TAVR patients had paravalvular
Yes.
leak. It's an exceedingly high incidence, even though they claim that it is mild.
Yes.
It reminds me of an old adage where they changed the bar level. In the olden days, we used to do triple ligation of PDA, and one or two RBCs going across. They will say, "Oh, there's a residual shunt." But now they put a ampliaxle device, and then torrential flow goes across, and then say, "No, that will slowly stop." So similarly, mild TAVR with mild this thing are just neglected. The other
Yes.
thing that you in your evaluation you should have brought about was also the lab parameters. Most of these most of these people will have most of these people have anemias, and so the hemoglobin level and also platelet count. Platelet count is also an important
Okay.
parameter to look for in these patients. And the standard incidence of thromboembolic phenomenon after a valve replacement is well known with various prostheses. And I'm just curious to know if there are any reports saying what is the incidence of thromboembolic phenomenon after a paravalvular leak occlusion, transcatheter paravalvular leak occlusion, because they're putting an additional foreign body there, and that will predispose them to definitely thromboembolic phenomenon and also valve dysfunction.
Yes.
This is something that needs to be looked into or studied in the future
Yes, sir.
things. Finally, is there any NH experience of transcatheter treatment of paravalvular leak? Have you
Yes, sir.
done any?
Yes, sir. Yes, I spoke with Uday sir and also with Suraj Narsimha sir. So it is very rare for them to get these patients, and very rarely they put a device closure. And basically, it's for a single, very localized paravalvular leak. And most of the times, in a surgical settings, post operative, like even on the day one, if there is significant paravalvular leak, then the patient is taken back in, and the defect is repaired or the valve is then again replacement is done again. That's
Yes.
what yeah.
Surgical management is the process, I mean, a procedure of choice, because it gives you a permanent solution. But these transcatheter devices, I'm not sure what is the long-term benefits and long-term results of these things in the future of these patients, because they are
Yes,
definitely prone for TE phenomenon.
yes,
Sir, any comments, sir?
Yeah, make must make a difference between the surgical valve replacement and the transcatheter valve replacement when you deal with the paravalvular leak. In surgical valve replacement, it may be either with a prosthetic or a bioprosthetic. In a bioprosthetic, after some years, they get actually a valvular regurgitation because of the degeneration of the valve between 10 and 15 years. They may get either stenosis or regurgitation. Paravalvular uh, leak after surgery is more common, as you said, in the aortic valve and the mitral valve area rather than the aortic. The aortic usage less, about 2 to 2.5 to 5, or the mitral usage about 7 to 17. The main factor is the risk factors for leak is one, not putting interrupted projected sutures and putting off just uh, sutures without projects. Then continuous sutures, especially in the mitral and also in the aortic, with the early in those cases, if one of the sutures cuts through, the the other sutures are also like to get cut through, and then severe valve paravalvular regurgitation, also tilting of the valve can occur. And also another risk factor we said is the supraannular position of the valve can produce paravalvular regurgitation. And those cases we always used to do. If it's a single point, try to repair it. If it is a continuous suture which is given to paravalvular leak, you always replace the valve. So that has got risk higher than the present day transcatheter closure of the paravalvular leak. Then there's some difference between the immediate symptoms of heart failure in patients with a prosthetic valve replacement and catheter valve replacement, especially in the aortic, because mostly for aortic stenosis, the TAVI is done for patients with either stenosis alone or significant stenosis with a mild leak, In such case, if there's a TAVI, the left ventricle, which is hypertrophic, is not used to the regurgitation and dilatation. Such cases go into heart failure early. They get end-diastolic pressure high, the LA pressure high, so they get into pulmonary edema. So there's some difference when you do a TAVI for a severe aortic stenosis and they get significant valvular leak, and the paravalvular leak, they go into severe symptoms. And the late symptoms, as you said, is a hemolytic anemia. That's actually, previously we used to teach, the reticulocyte count will go up, there will be jaundice, or the serum heptoglobin goes up. These are the laboratory parameters to do that. And you also describe very well the criteria for paravalvular leak in TAVI. One of the things is you said severe calcification of some area of the annulus, some friability of some part of the valve. Three, the angulation between the left ventricular outflow tract and the ascending aorta. Then less balloon dilatation than required because there are two types, self-inflating. And the paravalvular leak is more in self-inflating type of valve rather than the balloon dilatation type. The balloon dilatation type, if there is a paravalvular leak, you can try to dilate a little more if it is not. And then undersizing of the valve is another cause for the paravalvular leak. You're all used to only the surgical repair of nowadays, even if a prosthetic valve, little small, less than 5 millimeter, you said, paravalvular leak, can be treated by catheter closure.
Yes.
So that's, I think this is advancing because of newer devices and newer technique, And for a mitral valve, it's more difficult. It's antegrade transeptal or apical. These are the best methods, and they retrograde through the aorta and coming to the ventricle and going, maneuvering it through the mitral prosthesis and the paravalva. It's a more difficult procedure. So it's usually an antegrade to the femoral vein, to the right atrium, septum, and then occlusion of the paravalvular leak, But that's more difficult than
Yes, sir.
repair transcatheterally of the paravalvular leak of the aortic valve. And I think the mild regurgitation may be present in few cases, as you said, 50 to 80%. The significant may be about 10 or 15%, which require intervention. But things are improving, and especially diabetes originally was done in patients above 70 years, 75 years, were high risk of surgical procedure and who got comorbidity. So in such cases, try to repair a paravalvular leak by a surgery is going to be extremely risk. There is the importance of a transcatheter closure of the paravalvular. That's all right. But it will improve. I think the technique will come, and I think they for surgical closure of the TAVI, it will be more difficult than closing to a catheter maneuver.
Yes, sir.
Anything else?
It will be interesting to know what is the outcome of these patients after transcatheter closure. What is their this thing? How much the valvular leak has been addressed, and what happens to the leaflet motions, especially if there is a single valve, single leaflet valve, and also the thromboembolic phenomenon after the transcatheter. Because some of these devices that you showed are quite big, sitting in the annulus. So they are definitely going to cause leaflet motion abnormalities, leaflet this thing, because if it's a bileaflet, it may be okay, but if it's a single leaflet valve, they're definitely going to cause hemodynamic abnormalities. So maybe there are some case reports or articles saying you should make a search on that and see. It'd be interesting to know.
Yes. I think these patients are put on dual antiplatelet therapy for at least 6 months, That reduces the chances of polarization.
Okay.
Okay, thank you.
Any questions? Any other people have any questions? Senior PGs going for exams? Anything? Okay.
Thank
All
you.
right. Thanks, Reyes. Good
Thank you, sir.
presentation.
Thank you.
Yeah.
Thank you,
Thank
sir.
you.